Hi, I'm Luis Ortega for PCR Online and Aero Intervention, and today I have a really pleasure to host Professor Sanjit Jolly from McMaster University. He's Professor of Medicine and also is a senior researcher at the Population Health Research Institute in Canada. Very well-known researcher, first also of trials like the TOTAL trial, which was published in the New England Journal of Medicine. And he is the presenter and the senior author of a late-breaking clinical trial that is presented today in CRT meeting, and is a sub-story of the Universal trial. If we recall, Universal trial was a trial assessing the role of ultrasound guidance for coronary angiography. Professor Jolly, thanks for having us. Thanks for your time. I would like, please, if you can, for all the audience of Aero Intervention and PCR Online, you can do a wrap-up of the study, its rationale, methods, going to the results.
Okay, I think we all know that transradial approach is the preferred approach, the first line, but there's still a subset of patients where we need to do transfemoral access. And the question, of course, is ultrasound is gaining popularity in using it, but does it improve clinical outcomes? And so this was a simple randomized trial looking at whether routine ultrasound for access of the femoral artery reduces the primary outcome of BARC 235 major bleeding and major vascular complications. And this was a multi-center trial. We randomized over 600 patients. And what we found overall is that there was no difference. There was a trend, but not statistically significant for that primary outcome of major bleeding and vascular complications. But there were other benefits. You had less punctures, and you had less risk of hitting the vein, accidental venipuncture. What was interesting is that when you looked at and this particular analysis is looking at the pre-specified subgroup of those patients who got closure devices. And there was a hypothesis before that that this is probably very important, that closure devices and ultrasound there may be an important synergy. So we pre-specified it as an important subgroup, and we actually stratified the randomization by intent to use closure device to try to get at that issue. And what we found was that there was a particular benefit. In patients who got a closure device, there was a more than 50% reduction in major bleeding and major vascular complications, and a similar reduction in major vascular complications. And of course, this is a subgroup finding. So we need to be careful because, of course, the overall trial was neutral, and so this is really hypothesis generating. One of the other findings is we always teach our students, well, is the subgroup a chance finding or is it real? And as an interventionalist who uses ultrasound, it seems to make sense that if you can choose a site in the artery, free of calcium, free of disease, it's going to be safer to deploy your closure device. And if you can reduce the number of punctures that you hit the artery and you're going to use a closure device, it only closes one hole, so it's going to be safer. So it seems to make sense overall. And in addition, when you look at the totality of data, there's more than 4,000 patients in randomized trials, that in that meta-analysis, there is a significant benefit to routine ultrasound use. Back to you, Louis.
Okay, great. I fully agree with you, Professor, and I think I really like you highlighted that the case that in the JAMA publication there was some meta-analysis showing a benefit. We take all the overall evidence. There is I would say a very good quality data suggesting that ultrasound really makes a difference in terms of safety for this type of procedures. One of the clinical question I have, going beyond the methodological part, will be there was a substantial difference in the rate of the devices that were used. Primarily, they were used angioseal. Now that is different from the device is very different from the ProGlide, which was the second one. But the difference was like 85% for angioseal, 14% for ProGlide. Which is your insight of this? If this difference can have a role in the results of the study, or we can apply for both of them?
Yeah, I mean, I think that the trend when you look at the point estimates is similar. Obviously, we have a lot more angioseal. And I think from a biologic rationale, if you choose an area free of disease, irrespective of whether it's a collagen plug or whether it's a suture, it's probably beneficial. I mean, it was interesting in the structural space, ultrasound is ubiquitous. And because the risk of failure there is high, in other words, if you don't close a large bore access, it's going to bleed and you probably require surgery. And, it may be that, in fact, ultrasound may even be a bit more important for per-close or pro-style because the calcium, it can be a significant problem. So if you can choose an area of the vessel without calcium, that may help you in terms of the success of your sutures.
I think this is very important, and of course, I think it's reasonable, it's biological plausible that we think that it will be applicable for both technologies because probably depending on the area of the world you practice, you will have more angioceal, or you will have more per-close, or specifically according to the sites that are doing the procedures. My question, after following the story from the Universal that was presented last year, now with this presentation in the CRT of this very interesting pre-specified group of patients, what are the next steps in this field? Do the researchers in Population Health Research Institute are planning something else? Can you give a glimpse to the future if you think maybe running another type of trial in any specific population? And any insights from your side, Professor Jolly?
Yeah, that's a good question. Do we need to do, so we did a 600 patient trial. Do we need to do a 4,000 patient trial? And I think one of the first questions is, what is the harm of ultrasound? And I think what we've seen is that there is very little harm to ultrasound. There's been some concern that inexperienced users can have more high punctures, and specifically when they don't track the needle real time to see where they enter the vessel. But that wasn't the case in our trial. We didn't have more high punctures. And if you have a very low-cost therapy that is not harmful and the meta-analysis suggests benefit, I think probably we should put your effort into education and training. And doing mega trials of ultrasound guidance may not be useful because, the preponderance of evidence supports its use. It has no harm, and if you have a device there, it's really the cost of a probe cover. That's it.
Yes, I agree that, usually I think this is very common for drug trials. We look at the benefit harm ratio, but I think here, the harm is almost null, I would say. No, always there is something can be, cumbersome in some cases, but I agree that the harm is, and the benefit for the patients, I think is high. We are running out of time, but I have one more question. You are a well-known researcher, interventional cardiologist, and PCR online and other intervention. We have a very high scope for young people. I would like to, if you can give some thoughts quickly in terms of doing trials regarding this type of interventions to the young people on the community, so you can inspire them. We can have a new generation of trialists or people dedicated to this type of duties.
Okay, I think that's great. I think number one, we're not born trialists. You become trialists, and so many of us, including myself, didn't know when I was training that I was going to be a trialist. Second thing is, go after something you're passionate about, a clinical question you're passionate about. That's really, really important. Each trial takes from start to finish 5 to 10 years between getting funding, designing the consent, doing the case report forms. And so put your passion into something really important and then see it to completion. And each trial is like a child. It's born, it grows up, and it goes away. And so work hard, and it is fantastically rewarding, kind of like having children.
Thank you for your words, for kind words, Dr. Jolly. I want to highlight also that this is a simultaneous publication on error intervention. So all the people seeing us now in social media, please go to Error Intervention website. You can download the article. You can go into details. And of course, we will share as much as we can from CRT in social media. Professor Jolly, again, thanks for your time, for your expertise. Has been a pleasure.
Okay, my pleasure. And great meeting you, Louis.